Thanks very much, Wayne. Thank you, everyone, for your kind attention and for inviting me to provide a different sort of commentary or aspect of this paper. Bill Coleman and I were doing our usual thing at the Pump Jack on a Sunday afternoon. On or about the time this position paper came out that I think you've all seen around and hopefully have read about post-exposure prophylaxis. And then I started questioning myself in terms of where was my position in terms of what have I been doing to try to promote this process. And so my talk today is going to be focused on three things. I hope I don't digress too much. I have a terrible time when I public speak of kind of going off on a tangent, and sometimes you're kind of out there, and then to try to bring you back is kind of a bit strange. But anyway, so 3 points is one, public awareness, and I think Wayne has been very good about discussing the program to try to make people aware that there is something like a morning after pill or something that can be done if there's an act of some sort where someone feels that they may have been exposed to HIV, and therefore we could try to do something for that. So one is the public awareness to get this out to people. I will refer you to just a recent article. You can't see it, but anyway, this is Bill Coleman's article that just appeared in this month's Extra West that again gives a brief summary of the post-exposure prophylaxis program, and I think that the more we push, the more likely we're going to see some action. Second is the medical awareness in terms of what do emergency physician doctors do when, as usual, things happen on Friday nights or Saturday nights. And the whole point of post-exposure prophylaxis is to try to institute this as soon as possible after an act where there's been possible contamination with HIV. So the medical people have to be aware, and non-judgmental is also another thing. And the third thing, which won't take too much time towards the end, would be a change of the actual medications used in post-exposure prophylaxis, because right now, the medications they use have significant side effects, and certainly over the last, God knows, since 1996, we had the AIDS conference in Vancouver, that there's been just a plethora of new drugs on the horizon and the market. So it just strikes me that there's time we could actually change and improve these drugs and decrease the side effects. Post-exposure prophylaxis has been around a significantly long time, mostly for occupational reasons. So if someone is stuck by a needle, then and this is considered as high risk, then this treatment is started. The drugs that are used are very difficult to take because of side effects, and as a result, people are not completing the course of the medication because of the intolerability of the medications. So I'll speak about that. So the 3 points: one, public awareness; two, medical awareness and non-judgmental issues on the doctor's part about giving the so-called kits; and the third thing is about the change in medication. So I'll just talk about the timeliness of post-exposure prophylaxis. In 1996, the AIDS conference in Toronto, Dr. Montana brought out a very heretical concept, is that if you take a community and you treat everyone who is sick, first of all, so that's probably working with him in terms of getting more people tested and treating. The concept of treating people in the community is to decrease the viral load in the community and ideally to decrease the transmission of HIV. And so when you look at the concept of seeking and treating, and since 2006 to now, and the more recent conferences also, this position or this concept has gathered incredible momentum. And so when you consider, if you break it down to costs, purely costs alone, anywhere between $1,500 to $2,000 a month for someone who's infected. So if someone becomes infected and starts treatment, and God only knows when we're going to come up with an effective way to eliminate memory T cells to be able to try to eliminate HIV from a person's body, that for the time being, for the next 10, 20 years, potentially, someone would have to be taking these medications. So you do the math. $1,500 to $2,000 a month, multiplied by 12 months for a year, multiplied by 10 years, multiplied by 20 years. So I just see red when Wayne tells me that when he fired off a letter to Julio in the group, that they said that cost was an issue, when if you could give patients medication costing, say, $1,500 for 1 month to prevent a case, instead of waiting for that person to convert and then treating him for the next 10 or 20 years, I think that I just become very annoyed and upset that this is just a put-off. Philip Banks, I'm not sure if he's here or not, but he wrote a paper in Extra West shortly after the conference in Vienna talking about the AIDS, or at least the gay agenda seemed to be largely ignored in Vienna, and Julio seemed to have other issues in mind. But I think we have to bring him back to the reality of Vancouver and get him to give a position. I did write him a letter asking about post-exposure prophylaxis and opening up the access to it. Historically, occupational post-exposure prophylaxis has been around for, it's got to be at least 10 or 15 years. And the main person who's involved, I will not mention his name because it's not very fair, but he kept, his point was, if we offered this to openly to gay men, that every gay man who went out on a Friday or Saturday night and engaged in risky sex would be coming to St. Paul's Hospital or would come to his doctor and demanding or requesting post-exposure prophylaxis. Again, judgment and the total absolute bullshit nonsense is what he was. Is what he was promoting. But unfortunately, despite the fact that there is a thing called a Therapeutics Guideline Committee that Wayne has approached, that this guy is the guy mainly responsible for post-exposure prophylaxis. And so whatever has to be done has to go through him also. It's not just Dr. Montaner. So that's important to get a change in the perspective of trying to help treat. So my letter to Julio came back, and he basically just foisted me off and said that he was going to refer the letter to the Therapeutics Guideline Committee, the one that Wayne has been contacting. But slowly but surely, I think we're going to try to make some progress in terms of treatment. So at this point, what would happen in an ideal world? In an ideal world, that if there was an event where you thought there was a significant exposure to HIV, you would present yourself to possibly your family doctor if it was during the week, or to an emergency physician, and to ask me how many emergency departments in the city offer post-exposure prophylaxis. I'm not sure. I would certainly suggest St. Paul's, VGH, or Royal Columbian, where there's a kit, and the kit gives you a 5-day course of medication. And basically, the 5-day course of this HIV medication includes a protease inhibitor and 2 non-nukes that you would then take for the next 5 days. And then basically that just buys you some time to get to your physician and or healthcare provider of some sort, and then to judge the if it's a high-risk exposure, low-risk exposure, whether you should continue for the full 28 days. It's really tough. How could you go through to a ethics committee and ask them to look at putting if there's an exposure, an accidental exposure of some sort, that you're going to put a high risk exposure, you're going to put this person on possible or on prophylaxis, and you're going to take a control group and not do anything and just watch them. You would never get that by, and therefore the actual what can I say? The actual effectiveness of PEP is somewhat unsure or in question. But I just have to say, from a common sense point of view, if you have an unsafe sex act and within a window of at least 72 hours or so that you start the medication, it's there in the bloodstream to effectively stop the soiling, if you will, of the individual's bloodstream and lymphatic system and immune system, then it makes total sense to me that this is something that you could do, rather than just say, oh, go and have an HIV test now and go ahead and have an HIV test in 6 weeks and we'll be able to tell you if you converted or not. I mean, it seems totally absurd. So I think that having something, chemicals in place that we use to treat the disease, it just makes intuitive sense. So that's where we're at, and it also involves emergency doctors. I approached Dr. Rich, who was in emergency at St. Paul's yesterday, to ask her about the availability, and there's a standard folder actually in emergency at St. Paul's that I was unaware of, that said if someone came in and had said they had, if there was an occupational exposure, a rape, or a high-risk exposure, that you could ask for them to make available this 5-day kit, and how much judgment there is on the part of the doctor. It's interesting that if you read this poster, or at least this position paper, when a patient did exactly that, the doctor said that the risk was 1 in 5,000. I don't know where the hell anyone pulls a number out of the air of 1 in 5,000 risk of someone after they thought there was a high risk exposure of them converting or not, and ultimately that person did convert, and so that doctor was wrong, and so it just behooves the doctors in emergency to be more liberal about giving out these kits and then following up on them. Okay, I'll just move on a bit to the actual treatment, and I don't know how many of you are aware of the number or different types of antivirals that are out there in the market now. They just seem to be increasing by the year as newer formulations from integrase inhibitors or CCR5 receptor antagonists come along stream. But for right now, if one goes to St. Paul's Emergency and picks up the kit, one gets Kaletra, which has been around for a long time. One gets 3-TC or lamivudine, and one gets tenofovir. That is what's in the kit for the 5 days, and presumably you would then go to your doctor, and if the risk was high enough exposure, with some phone calls, you would then get the other 23 days worth of medications, to a total of 28 days of taking the medication. Kaletra is a wonderful drug, certainly no comments about its potency. It's extremely potent. There's one very serious side effect of it. It causes intense GI upset and diarrhea. And so, but this drug has been sort of in place just for a long time. Now, did they ever do studies where they actually looked at different drug therapies to find out which one would be better in post-exposure prophylaxis? And the answer to that is no. They just kind of chose what was kind of convenient and best at the time, and chose to make that the standing drugs that are used for treating this, for use in this treatment. and just to me, it seems to me that over the while there has been with the increase in newer drugs in the market that I could recommend that something like boosted atazanavir or raltegravir, an integrase inhibitor, might be a very reasonable alternative to these that would be much better tolerated. Because what is the point of getting medication if the side effects are so onerous that the likelihood of your finishing them is low or poor, and I'm going to be maybe snide or snarky to suggest that maybe they're thinking, well, geez, if you're willing to take these for even just the 5 days and so on, you'll never ever again want to take them because the side effects are just so awful. Okay, so I think I'm running out of time, and I think it covers my point. One, public awareness that post-exposure prophylaxis exists, and Bill's great article in Extra West and your wonderful position paper. Two, the medical awareness and emergency doctors being more liberal in giving out these kits, and three, changing medication. I don't have any more time at this point, so I won't talk anything about PrEP, the so-called pre-exposure prophylaxis. But I got to say that when this article came out this week and was in the Sun about use of Truvada in prevention of HIV disease, I was very upset because I just thought that this drug company is just trying to make its money by giving this drug to people. The concept would be that you put people, I don't know who, on this drug prophylactically. If you took it continuously, there was about a 70% reduction in transmission of AIDS or transmission of HIV. And if you took it sporadically, say you took it on a Thursday, Friday, Saturday night, because that's when you're going to be having sex, there was only about a 30 to 40% a risk in transmission, and I have no idea how this paper ever got through any ethics committee, because it just sounds to me like I just don't know who would start it, when they would start it. 18, 19, 20-year-old person would start taking it for the rest of their life to try to prevent transmission of HIV, and so it's been very controversial this week, and I'm sure it's going to cause even more controversy, but I just don't understand the ethics of it. Okay, I'll finish, and if there are any questions, I think we're going to have a board or panel here.